I think that today one of the most challenging topics is what to do for those patients with oncogenic-driven non-small cell lung cancer and brain metastasis at baseline. Obviously, before that we had in our daily clinical practice the next-generation TKIs, it was more challenging. However, today this next-generation TKI has a higher brain penetration and a higher intracranial response rate. So for those tumors or for those patients with the most common oncogenic drivers, EGFR mutation, ALK rearrangement, and also ROS1, probably the first step for those patients with baseline brain metastasis is to start with a TKI. And probably we can delay the use of radiotherapy for those patients who relapse after the initiation of this treatment. Another potential challenging question is whether exists or not an heterogeneity in the percentage or on the oncogenic driver either in the primary tumor compared with the brain metastasis. And despite that might exist approximately 10% of potential heterogeneity in the brain metastasis, we have seen that in our daily clinical practice, there is not a discordant response rate either in the extracranial versus the intracranial, meaning that probably the tumor is homogeneous in the oncogenic driver either in the primary and also in the brain metastasis. Of course, today another challenging question is whether there is any subgroup of patients with a specific oncogenic drivers that might get benefit of the combination of the TKI and radiotherapy. And today, this is a challenging question that should be clearly answered in an ongoing clinical trial.